Welcome, everyone, to the Cholangiocarcinoma Foundation Annual Conference. I'd like to thank the Foundation as well as the selection committee in giving me this opportunity. I'm Kanwal Raghav, one of the GI medical oncologists at MD Anderson, and one of my chief areas of interest in clinics as well as in research is HER2 amplified solid tumors, especially GI malignancies. So these are a couple of my disclosures. Today, I've been tasked with this exciting opportunity to discuss the prospects of HER2 targeting in cholangiocarcinoma in light of established and emerging therapies. It is a really exciting time in this field because of the armamentarium of HER2 targeted drugs that we have at our disposal. Furthermore, the prior success of HER2 targeting in breast cancer has laid the foundation of this immensely promising therapeutic strategy. Before we go on to some of the therapeutic strategies, I want to do a quick overview of the HER2, or what we call as ERBB2 signaling. One way of looking at this signaling is to imagine that HER2 is a part of this HER family of receptors. The most famous among these HER family of receptors is actually HER1, which is EGFR and is commonly targeted in many GI malignancies through EGFR inhibitors, whether they are small molecule tyrosine kinase inhibitors or monoclonal antibodies. The HER2 is the second member of this family, and then there are two more members, HER3 and HER4. These members differ in whether they have a ligand or they don't have a ligand, how they homodimerize or heterodimerize. Whenever a HER family of receptors heterodimerize, i.e. dimerize with another HER family member, HER2 is one of the preferred partners, and therefore the importance of this particular receptor. The EGFR is most commonly activated by a ligand. On the other hand, HER3, for example, doesn't actually have intrinsic tyrosine kinase activity. But overall, any of these factors, including HER2, whenever they get activated, they stimulate downstream signaling through RAS-RAF MAP kinase pathway, PIK3, AKT, mTOR, NF-kappa B pathway, and the phospholipase C and protein kinase C pathway. They modulate enzymes that promote cell cycle progression, proliferation, and survival in cancer cells. And that's the role it plays in pretty much many tumor types. But whenever we talk about aberrant HER2 signaling can happen from two different aspects. One is a quality issue, right? You just have a lot of HER2, so you're HER2 overexpressed or HER2 amplified, and the reason why you're overexpressed is probably because you are amplified and your genes are producing a lot of HER2 protein. And as a result of that, there is a lot of homodimerization of HER2, and this activates the pathways going down. And the HER2 amplification and overexpression is commonly tested in clinic using immunohistochemistry, and it is commonly scored as HER2 0 all the way to 3, depending on the intensity of the scoring, the intensity of staining. And the HER2 amplification is often tested by in situ hybridization, whether it is fluorescence or dual. Basically, you tag a probe to the 17 chromosome, so that's the CEP17 part of it, and you look at the number of genes per the CEP ratio. So you calculate this HER2 CEP ratio, and as long as it's greater than 2, it's often recognized as being HER2 amplified. The other part, which is less commonly recognized, is that there are HER2 mutations that can activate this pathway, and many of these mutations affect the kinase domain, sometimes the extracellular domain, but mostly the kinase domain. And even in that kinase domain, one of the most common ones is this V77L, which is an exon 20. And there are lots of insertions. This is commonly seen in lung cancer, but is found in other tumor types. And whenever you see these mutations, they also have oncogenic and their potential and therefore therapeutic opportunity. However, HER2 amplifications and mutations are sort of distinct mechanisms. So if in this slide, we just have a summary of studies that looked at HER2 amplifications and mutations. And the reason why we're discussing lung cancer is because it's one of the unique tumor types where the amplification rate is much lower than the rate of mutations that are found in this disease. And you can find that there is pretty much no correlation between having an amplification or a mutation. So many of the mutated tumors are non-amplified and some of the amplified tumors are non-mutated. In cholangiocarcinoma, the landscape is actually very interesting, right? So this is a C-bio pan-cancer histogram showing the prevalence of HER2 amplification in multiple tumor types. And you can see, of course, the most common one here is gastroesophageal, esophageal adenocarcinomas, which are commonly exploited in GI cancers, right? Breast cancer falls somewhere here where all of these are between 20 and 30%. But then you have a smattering of tumor types where it is a sub 10% ratio, and you can see gallbladder cholangiocarcinoma and extrahepatic cholangiocarcinoma are slightly different in that category, but the expression level can be anywhere between, say, 3 to 5 to 7%, which makes it a very viable target, in my opinion. The HER2 mutations can also occur in ampullary cancers, and to a certain degree in gallbladder cancers and cholangiocarcinoma and other tumor types. But both these alterations play some role in cholangiocarcinoma. So if you look at the landscape of cholangiocarcinoma compared to other molecular targets that we are trying to exploit here, you can see that HER2 amplification is seen in about mutations or amplifications are seen in about 6% of these cases, compared to, say, 17% in IDH1 mutation or 6% in FGFR2 fusions, which are the other common alterations that we've gone after in cholangiocarcinoma. And you can see that, compared to MSI high, this is still a favorable prevalence pattern and almost the equivalent of FGFR2 fusions. TMB has come out to be another biomarker, but you can see that the mutation count or the impact scores in cholangiocarcinoma are not significant. So it makes this a very, very viable, exciting, and definitely an unmet need in cholangiocarcinoma patients. So the best part about HER2 as a target is the vast number of ways in which you can target this, right? So you can start by inhibiting the dimerization of the receptor by putting an antibody like, say, pertuzumab. You can promote receptor internalization and degradation when you attach trastuzumab, therefore decreasing the signaling from HER2. Sometimes you can use antibodies like margetuximab, which engages this and stimulates ADCC or antibody-dependent cellular cytotoxicity. You can tag these antibodies to a very potent cytotoxic and make an antibody drug conjugate. Those are readily available. You can directly inhibit the receptor tyrosine kinase activity using small molecule tyrosine kinase inhibitors like lapatinib. And then you can sometimes do dual targeting, either by using a combination of two drugs or bispecific antibodies. So variety of strategies. And the number of drugs that are available for this is mind-boggling, right? So many of these drugs in clinical trial, at least 3 or 4 of these drugs that have been already approved by the FDA. 2 small molecular tyrosine kinase inhibitors, 2 antibodies, 2 antibody drug conjugates, TDM1, DS8201. But this slide is essentially to emphasize that if we want to go after this target, sky is the limit from a clinical feasibility perspective in terms of drug availability. So I'm just going to give you a quick rundown of some of the activities that we have seen with all these drugs in clinical trials for cholangiocarcinoma patients. But before I go on to that, I want to tell you this little anecdote or story that I have about HER2 amplified patients, which I haven't found a whole lot in other molecularly targeted therapies, right? So in HER2, if you look at breast and the evolution of breast cancer, you're targeted by dual anti-HER2 inhibition with trastuzumab, pertuzumab, and you get improvement in overall survival and great response rates. You change that strategy and bring a different strategy. So instead of like blocking the signaling, you just change your strategy, and now you develop an antibody drug conjugate, which acts more like a smart bomb, delivering a cytotoxic, and you give TDM1 to patients who were already treated with these treatments, and you find another improvement of overall survival and great and promising response rates. And then you take the same strategy, which is ADC, and change the cytotoxic to DS8201, in which case it was a topoisomerase compared to a microtubule inhibitor here, and you again continue to see responses in these patients. So HER2 amplified GI cancer patients can go through multiple lines of HER2 directed therapies and have prolonged outcomes. So this is the first study, which was a basket study for neratinib in HER2 mutant baskets. You can see that there are smattering of responses in biliary tract tumors, about maybe a 25% response rate. But what you notice is almost both of those response rates here were in the kinase domain hotspots, right? However, it doesn't matter, because as we change our strategies, we could encompass larger proportions of HER2 mutations that can be successfully targeted. But this is an example of a receptor tyrosine kinase inhibitor working in biliary cancers. This is the analysis of trastuzumab, pertuzumab through the MyPathway study. This is dual anti-HER2 inhibition. It binds to HER2 and prevents its dimerization. There were about 7 to 11 patients with biliary tract tumors that were treated on this study, and you can see there was a response rate of about 30% in these patients. Then again, you look at HER2 amplified or overexpressed versus HER2 mutant tumors, small numbers when you drill it down. But what you find is that your response rates are present in both mutated as well as amplified and overexpressed tumors, right? So great way of like targeting both these alterations, and proof of principle that both these alterations can be targeted easily by either tyrosine kinase inhibitors or dual anti-HER2 inhibition. Then you do another kind of dual anti-HER2 inhibition, but this is ZW25. This is a bispecific antibody that attaches to 2 domains of the HER2 receptor. There were about 9 patients of biliary cancers treated on this study with a partial response rate, a very promising partial response rate of 66%. Right. Again, this was essentially for HER2 amplified patients. So again, really good options for a really good option for treatment nonetheless. So for example, if you look at this patient here, he has 3+ IHC, 3+, 3+. Sometimes you find these 2+ patients that don't respond because it could be dependent on, HER2 heterogeneity, presence of concomitant mutations like RAS mutations, which can nullify the effect of HER2 inhibition. And then, we come to the ADC mechanisms. These ADC mechanisms, this is TDM1 basket study from the NCI match. You can see, apart from breast and gastric, one of the most common tumor types that you would enroll on such a study is hepatobiliary tumors. And you can see, 1 out of 3 of these patients responded and 2 actually had some sort of tumor regression. Similar to DM1, with a different cytotoxic and a better linker technology and a higher drug to antibody ratio, is a drug called DS8201. It is attached to a topoisomerase inhibitor. And in this large study, which was their basket study, they had 2 patients, one with gallbladder, one with cholangiocarcinoma, both of which actually had a response. And the gallbladder was actually 2+ amplified, and the cholangio was actually 3+ amplified. So again, could happen in either one of those situations. So, this was just a quick glimpse of like the drugs that are available to target HER2. Clearly there are other drugs, newer drugs that are coming in are bispecific antibodies that are exploiting the immune system, some HER2 peptides, and even CAR T cell therapies that are directed towards HER2. And clearly, from the prevalence patterns, it does look like biliary cancer is a good option for this, with about 15% amplifications, 20% overexpression, and then some mutations. But as HER2 therapies evolve and as these strategies evolve, so will the spectrum of treating this, right? So initially we used to think that only amplified and overexpressed patients can respond to it, but ADCs like DS8201 are bringing about responses even in 2+ and 1+ breast cancer, which immensely increases the number of patients that we can successfully target as long as they have HER2 expression. And then, strategies against mutations go in the similar way. So in conclusion, HER2 is a low, but a very promising and targetable subset in cholangiocarcinoma. HER2 therapeutics have multiplied beyond imagination, but the type of therapy to be applied depends on a complex interplay of what's the tissue, what's your alteration, and what is the mechanism of action of the drug, and whether you've had prior HER2 therapies or not. There is still an immense need for preclinical and translational data, along with some larger trials. As you can see, almost all the trials that I showed you have treated about 8 to 9 patients with cholangiocarcinoma, but dedicated and more collaborative efforts are required to take something beyond the finish line. And then I think one of the places where the foundation can play a role, and this group can play a role, is to create a clinical and translational framework for patients that are being enrolled in different clinical trials across the United States and the world, and try to learn as much from them as possible. With that, I'd like to thank you for your patience and listening to me. I'm happy to take any questions during the panel discussion. Thank you.
Thank you very much. Good morning or good afternoon, all depending on where you're located in the world. And thank you for logging on to this session. Also, thank you to the organizers for the invitation, as well as the CCF staff for their hard and challenging work shifting the Salt Lake City conference into this virtual meeting as a consequence of COVID-19. My name is Jesper Andersen, and I'm the head of the Andersen Group at Biotech Research and Innovation Center at the University of Copenhagen in Denmark. And I will, in the next 15 minutes, try to take you through the current state of epigenetic targeting in cholangiocarcinoma. A key importance of the CCF meeting is, of course, the connection between both research, clinic, and patients. And I would therefore like to start by taking you through a few slides with a little bit of background so we all know what I mean by epigenetics. So what is epigenetics? Epigenetics includes 3 main layers of regulatory mechanisms which act on top of the genome. That is non-coding RNAs, chromatin modifications, and DNA methylation. We have to remember that each of these epigenomic layers are pieces of the puzzle and are interconnected and all play important roles in cholangiocarcinoma development, progression, metastasis, and response to therapy. As shown here, non-coding RNAs play key roles among others, both in proliferation of cholangiocytes, in the response of drugs causing, for example, resistance, and even in epigenetic mechanisms themselves. As an example could be MIR 1249, recently published in Hepatology by Professor Chiara Branconi, and showing its ability to regulate response to therapy. Chromatin remodeling here, the data is relatively limited in comparison to non-coding RNAs. But what it is clear is, however, a significant enrichment of mutations of genes involved in chromatin regulation, particular genes such as IDH1 and 2, and genes involved in the Swift-SNU complex. Besides that, DNA methylation, which constitutes a chemical modification on the genome, a methyl group on the 5' side of cytosines. In this presentation, I will focus on the aberrant DNA methylome in primary cholangiocarcinoma and its role in metastasis. The malignant transformation of normal cholangiocytes is accompanied by growth insult to the epigenome, here shown as a particular DNA methylome dysregulation. This is mediated through diverse mechanisms which impede DNA methylation catalysis, including the mutations in IDH1 and 2 that I mentioned earlier, epigenetic alteration, for example, DNMT targeting microRNAs, as well as even autocrine factors such as elevated level in IL-6. So are epimutations a missing link? Epimutations are defined as any non-homeostatic epigenome remodeling event and are being increasingly considered as functional synonymous to genetic mutations. However, essentially all of these support has come from outside hepatobiliary space or outside cholangiocarcinoma. Important are, unlike two mutations, epimutations are reversible, as shown here, as they are catalyzed by writers and eraser enzymes throughout the cell cycle. Notably, findings include clonality of epimutations, and this has been shown particularly in leukemia. More generally, the potential of epimutations are to function as drivers or passengers in disease at distinct time points throughout transformation, whereas efforts to identify mutations causing metastasis have largely failed. Extensive epigenome remodeling has indicated to be a driving role in metastasis, and this has been shown particularly in PDAC in pancreatic cancer. DNA methylation or aberrant DNA methylation is used as our epigenetic readout in these studies that I will be presenting. DNA was subjected to bisulfite modification to discriminate methylated from non-methylated cytosines, and then profiled either on 450K human arrays from Illumina, or this, as shown on the right-hand side of the slide, EPIC arrays with 850 single nucleotide resolution sites, methylation sites. The arrays are used to quantify methylation changes throughout the genome. DNA were processed through a stringent informatic pipeline called RNBeats, and methylation levels were quantified using the beta value metric, indicating that methylation, at the degree of methylation between 0 unmethylated and 1 fully methylated. Finally, epimutation were called between the groups. So the presentation will include two parts: epigenetics in the development of cholangiocarcinomas, where we will look at a cohort of primary disease, and in the second part, the metastatic disease. An early study performed together with Professor Derek Chang where we compared IDS mutated intrahepatic cholangiocarcinoma methylation with a pattern of glioma. At this point, the IDS mutation in intrahepatic cholangiocarcinoma was new. In the study, we showed enrichment of methylation at the CPT shores. This is the right part upstream from the transcription start site, suggesting a global transcription deregulation. This was clinically associated with reduced risk of disease recurrence and longer overall survival. More than 50% of the gene targets overlap with glioma, suggesting a common gene set. This was followed followed by another study. Here, our IDH patients in the previous slide is relative to the patient in cluster 4, indicated in the study by Jesper et al. Besides, they also overall defined 2 sets of hypermethylated CCA patients, patient groups, into the cluster 1 and cluster 2. Cluster 1 is interestingly associated with CPD island hypermethylation and liver fluke related tumors, increased mutational rate, downregulation of DNA methylation, demethylation enzyme TET1, upregulation of histone methyltransferase EZ2, and the increased level of deamination events, C2T mutations. Patient in this group has the overall poorest survival. Now, these studies do not all consider all driving events in the intrahepatic cholangiocarcinoma besides IDS. Therefore, I would like to highlight, even though I showed the study to you last year in Salt Lake City, our integrated omics approach stratifying close to 500 intrahepatic cholangiocarcinoma patients into 4 categories: IDH, KRAS, TP53, and patients with wild-type genotype for these genes. In fact, the undetermined patient group subset turned out to also be enriched for FGFR2 fusions, but this is not shown in this slide. Of course, one of the levels of DNA of data we tested was DNA methylation, and as shown here, not surprisingly, we have high methylation phenotype in the IDS mutated cases, whereas in KRAS and P53 mutant intrahepatic cholangiocarcinoma, they are relatively methylation silent tumors. Importantly, and that's the main emphasis of our study, was to test each of these tumor categories against a large late-stage drug library. To our surprise, we defined a very unique categories of drug response in each of these patient subsets, as seen on the right-hand side. In fact, the reason for discussing this is that we demonstrated that mutations in recurrent driver genes often cooperate with chromatin remodelers, most significantly seen in the IDS mutant subset of patients, as shown with the red circle, but also in the 4th category of tumors comprising the undetermined ICCs. Therefore, knowing from several studies that intrahepatic cholangiocarcinoma portray a hypermutator, methylator phenotype, we went back to our data repository. We defined recurrent epimutation in a large cohort of primary cholangiocarcinoma, 186 patients, but also in hepatocellular carcinoma and collision type tumors, the CHCs. Tumors with morphological and histological features of both PLCs. Due to the cellular composition in bulk tissues and a likely cell-specific methylation pattern due to this, we tested both matched normal surrounding tissues adjacent to the tumor site, as well as independent normal livers as microdissected common bile ducts as control samples. Corresponding normal bile duct control tissues uncover intrahepatic cholangiocarcinoma as predominantly hypermethylation-driven cancer, whereas HCC as a grossly hypomethylating malignancy, so losing methylation, which is what normally would be expected. Interestingly, the collision type tumors, the CHCs in the picture, was shown as an epigenetic intermediary between the two subtypes of PLC, HCC, and ICC. As such, collision-type tumors indicate no clear methylation signature exists, with different patients mixing among both HCC and intrahepatic cholangiocarcinoma. Quantification of the methylation, however, methylation changes, however, still suggest a defined epimutation confirmed in the collision-type tumors as mixing between the two phenotypes. Not showing here, but we also analyzed pan-cancer, 17 cancer types on more than 6,000 tumors. And here we can confirm that intrahepatic cholangiocarcinoma indeed is the greatest hypomethylating, has the highest hypomethylating profile, whereas HCC is the one with the most extensive hypomethylating disorder. Principal component analysis demonstrates separation of HCC and CCA into intra and extrahepatic. As a control, we did random permutation test, and in all cases we see the same hypo or hypomethylation phenotype between HCC and CCA. We also see a hypomethylation in both intra and extrahepatic cholangiocarcinoma. Since primary liver cancers behave so differently from their epigenetic processes, we considered whether they were targeting different regions of the genome. Comparison of recurrent epimutation by forest plot confirms this, that ICC epimutation typically targets regulatory regions, promoters and enhancers, CPT-rich regions, whereas HCC epimutation predominantly recur in CPT-depleted regions. Next, we segregated epimutation based on promoter and gene body association and found the same results. Pathway overrepresentation analysis of recurrent intrahepatic cholangiocarcinoma epimutations indicate a substantial role of epigenomic remodeling in classical cancer hallmarks. This is relatively silent in HCC. However, but not shown in this slide, there is large changes of in earlier stage for HCC, so in cirrhotic nodules towards HCC, we see a large cancer-promoting network aberration. So does the predominant epimutation load in ICC present a therapeutic potential in epidrugs? It certainly do. We tested in part of our library I showed you earlier, 59 epidrugs. We tested this sub-library in 8 different cell lines, and regardless of their genetic background, we found a predominant, primarily activity of BET and HDAC inhibitors. This we still need to test further. So moving to the second part of the presentation, in the next 5 slides, we will discuss CCA dissemination and by analyzing CCA metastasis. This is important and highly under-investigated area of cholangiocarcinoma. We have to remember that 70–90% of patients are diagnosed with locally advanced or metastatic disease. As such, we wanted to investigate epigenetic alterations in metastatic disease. To this end, we obtained a rapid autopsy cohort comprising both HCC and intrahepatic cholangiocarcinoma patients. This is a relatively rare cohort, but admittedly also a small number of patients, but still multiple samples of metastasis per patient. In both autopsy cohort, the patient were mixed etiology, mixed stage at the time of diagnosis. However, all samples showed a relatively homogeneous histology, cytology, and grading. Now we do exactly the same as we did in the part 1. We analyzed the primary tumors, intrahepatic intracancer comparison of epimutation modes reveal hypomethylating HCC, hypomethylation intrahepatic cholangiocarcinoma. Interesting, the quantification of methylation changes between primary and metastatic tumors revealed a shifted epimutation mode from the observed non-metastatic disease, with increasing loss of methylation and metastatic CCA and vice versa in the metastatic HCCs. Following extensive cellular deconvolution, the hypomethylating mode of intrahepatic cholangiocarcinoma metastasis present a significant enrichment of expression of diverse metabolic networks. Network hotspot analysis uncovered extensive cytoskeletal remodeling and by epimutations. In fact, linking epigenetics with histopathology Patient predominantly maintained the histomorphology between primary and metastatic tumors. Here shown the two cohorts, CCA cohorts next to each other, the primary tumor cohort and the metastatic cohort. You can see the loss of methylation as metastasis occur. For patients with 2 or more metastases, we then performed phylogenetic or epigenetic reconstruction, confirming that the disease or ICC followed a branched evolutionary pattern, the same as is typical for other cancer types. So again, following a stringent cellular deconvolution approach, we enriched specifically for aberration in metastatic tumor epithelial. Large proportion of the aberrant methylation site were associated with stromal compartment and they were excluded. Removal of these indicated a high confidence that these events that occur in the metastatic cells rather than occur in the metastatic cells rather than the surrounding local tissue at a metastatic seed site. We demonstrated that DNA methylation reprogramming signature acting predominantly through the Wnt and immune pathways. This we, however, need to further investigate. Importantly, this is independent of key genes influencing DNA methylation. We also evaluated the predictive nature of the DMR, or the differential methylation region signature, and the area under the ROC curve shows defined DMR discriminate that the defined DMRs discriminate the primary tumor from matched distal metastasis. So I hope that I have convinced you that epigenetics play an important part in the initiation and progression of cholangiocarcinoma, affecting tumor phenotype in the absence of changes in DNA sequence. Deregulated patterns of methylation, histone modification, and aberrant expression of non-coding RNAs promote unbalanced transcription and gene expression that impair cell homeostasis and sustain malignant transformation. In conclusion, intrahepatic cholangiocarcinoma is a predominantly hypomethylating disorder, preferentially affected in regulatory regions and CPD-rich regions, affecting cancer-related processes, and it's the opposite in hepatocellular carcinoma. In both cases, they are epimutational clonal and target cytoskeletal networks. Besides the recent approval of anti-FGFR2 fusion inhibitors in advanced CCA IDH1 mutant patients, may soon have a therapeutic option in Epigenetics. As well, we have to consider that there are, or we should not forget that there are a high degree of alterations in chromatin remodeling genes, and these may present untapped opportunities. However, when going back to Jesper et al., their patient stratification suggests that we are only therapeutically targeting patient in group 4, since they are both the FGFR and IDH affected patients. This is the group. This is my group. They are the ones doing all the hard work, and very much thank you to them. This was a collaboration with Matthias Matter in Switzerland, and thank you to all collaborators.
Right. Well, I'd like to thank all of the speakers for their great talks, and I've really appreciated seeing the questions come in over the chat while the talks have been ongoing. I think we'll leave a couple of extra minutes for additional questions to come in, but I'd like to lead with a question for each, and then I've picked a few from the chat session that I can share as well. So I think my first question is to Dr. McNamara, who gave us a very thought-provoking talk and sort of took us in a more spiritual direction to start the day. And, I think so I'm a physician and a scientist, and I think a lot about how to effectively communicate with my patients around the kind of issues that she discussed. And I'm curious if Dr. McNamara has, from her experience, has identified a place where her perspective and the perspective of her patients have diverged over time, and how she's been able to bridge those gaps, specifically around sort of how we prepare for and react to the anticipation of death.
Okay, thank you very much. So I suppose with time, when you're dealing with patients, comes experience as well. And I think in the beginning, sometimes when you're dealing with questions for patients and families, sometimes it's about dealing with expectations. And you always learn from people you've seen what way they do it as well. So I would say the first thing is always to acknowledge what the patient is feeling. And then every patient will be slightly different. The other thing is to always try and find out, I would think, what they actually want to know, what the patient wants to know, what the family wants to know, and if the patient is okay for the family to talk to you separately. Because sometimes there's different levels of information that they can deal with, families and patients. And sometimes it's the patient wants to know and the family aren't keen to know. So and I think everyone is different, and you have, there's no script. And I would think often as well, dealing in the beginning, it's often anger in the beginning with the diagnosis, and then sometimes it's maybe turned on the physician in some ways a little, and you have to, I suppose the thing to remember is that it's not directed at you personally. It is at what's happening, and trying to learn how to deal with that, it can be difficult over the years. And there are sometimes when I suppose even in the particular time we're living in at the moment, I think it has been it's more difficult because they have other things to deal with as well, as if they hadn't enough to deal with already. And again, I think we're all learning all the time, and you have to do your best. And I think the other thing is, as well, from a physician perspective, sometimes you feel that people don't realize that actually you are not so different to them, that you have had these experiences too. And they may see you as someone who can deal with everything, which you can't always.
Yeah, thank you, and I agree that it's definitely a lifelong learning, and definitely a conversation that starts the first time I meet a patient, and something that evolves over the course of the clinical care. And again, thank you for sharing your thoughts on this very important topic that doesn't always come up in conferences like this. One question for Dr. Raghav, which was one that I had been thinking about during his talk and also came up from one of the speakers, or from on the chat session. So one of the things that is very well established in breast cancer is the thresholding for HER2 amplification. How many copies are amplified, what the IHC signature is. In gastric cancer, in general, the thresholding seems to be different, particularly around the IHC signature. What do you use in your practice to define a patient with biliary tract cancer as being HER2 positive based on amplification?
Right. So that is actually a very clinically relevant question. Data has shown us, and intuitively speaking, if you have a higher gene amplification number, the more is your oncogenic addiction to that pathway, the higher likelihood that you'll get a response rate, right? Breast and gastric are way ahead of other GI tumors in figuring that out because they have larger trials that have been done. In colorectal, we found that there is, certain gene copy number cutoffs depending on the study that you look at, where the response rates are higher. That does not mean that there cannot be, response rates in. So, for example, you could have a gene copy number that's 5 but have a PIK3CA mutation, and a gene copy number of 3 but no PIK3CA mutation. My guess is that it's more likely that the second patient is going to respond than the first patient, right? So I think it's a multifactorial thing. For now, when we are in the early stages of this development, I think that we should give the benefit of doubt to the patients in clinical trials, and therefore our thresholds for all our clinical trials currently is what is consistent with breast guidelines. As we treat more and more patients, we will figure out what that cutoff is. And to be fair, I think that cutoff is going to be a very dynamic target depending on what drug you're using, right? So for example, in DS8201 study in breast cancer, they found and even in gastric cancer, they found response rates in even 1+ and 2+, or what we call as low HER2 expressing cancers, right? So I think that definition is going to change. And that would be very important because it also determines the modality that we use, right? So for example, the common modalities of next generation sequencing usually capture high level amplifications, but they may miss low expressing tumors, right? So I think as far as pertinent to cholangiocarcinoma is concerned, we should consider, testing for HER2 either by IHC or by the common available the sequencing platforms. Sequencing platform have their own algorithm of calling stuff. But as far as in clinics are concerned, I think any person who has a HER2 CEP ratio greater than 2 should still be considered for a anti-HER2 directed therapy.
Thank you. And do you mind if you don't mind, I'll keep the spotlight on you for a couple more minutes because there were quite a few questions. One question which came from the audience, and I think you agreed in advance to answer, so I'll hold you to now, is talking about the distinction between HER2 and HER3 targeted therapies. And this is actually an area of drug development that I sort of missed because I know there were some HER3 antibodies. Obviously, we can't use small molecules, but if you could give us a brief rundown on that, I think that would be much appreciated.
Yeah. So my task was to deal with HER2 targeting, but I think that it's very difficult to discuss HER2 targeting without discussing HER1, HER3, HER4 targeting because there's so much extensive crosstalk of these molecules, right? So the question essentially was like, what is the basic difference between a HER2 and a HER3 target? And that depends on the characteristics of the receptor, right? So for example, if you have a lot of HER2, you're going to homodimerize and cause activation, right? Mm-hmm. However, HER3 by itself doesn't do a whole lot of homodimerization, and it's more or less a tyrosine, like the kinase activity dead kind of a receptor. However, if you have a high HER3 expression, you have a more tendency to heterodimerize with HER4 and HER2, and therefore activating those receptors. And that's why a lot of data in GI tumors shows that it can lead to EGFR resistance, HER2 resistance. So that's why single agent HER3 agents have not been very successful, even though the expression of HER3, if you look at it, is higher than that for HER2, right? But therein lies the opportunity of exploiting either combination treatments or strategies such as ADCs and bispecific antibodies with immunotherapy, which use the receptor as a beacon to localize tumors and then, exploit some mechanism of resistance. And, there are other things that are coming up, radio drug conjugates, radioisotope drug conjugates are also another option. ADCs are an option, and so are bispecific antibodies with TLR agonists and CAR T-cell therapies, right? So I think this is going to be a very exciting field. And it looks like with improving technology and how we've improved our ADCs will help us expand a large number of these patients under this basket of HER family receptors and targeting them.
Thank you. No, and I definitely want to hold some time for Dr. Anderson. I could go on all day with these questions, but if I can ask you one more brief one more brief question for Dr. Raghav, is for those patients for whom travel for a clinical trial might be more challenging or, relatively inaccessible. If you encounter a HER2 positive patient in clinical practice and you're not operating in a clinical trial setting, do you favor trastuzumab, pertuzumab combinations, trastuzumab with chemo? What would be your advice to the community oncologist encountering this in their practice?
Right. So just my personal thought is the amount of money that we invest as a society in getting drugs for patients, that otherwise have no access or are finding hard to access is much less than the amount of money that we would actually use to get these patients access to those clinical trials personally, right? I mean, that's a philosophical thing. And I really think that if for some reason, because we always start searching for these off-protocol therapies, right? And the reason why we are searching for off-protocol therapies is because we just haven't had big enough trials to get these drugs through the home stretch and get them approved so that every patient has access to it and they're not left at the whims and fancies of their insurance companies, right? But keeping that aside, if I do encounter a patient who I think would benefit from HER2, but they cannot participate on a clinical trial for some or the other reason, my personal bias is not towards using single agent anti-HER2 therapy, right? In GI tumors, the single agent anti-HER2 therapy, and even in breast cancer for that matter of sake, we've kind of completely gotten rid of using single agent trastuzumab. Even with combination with chemo, we use it in combination with pertuzumab. So what I would strongly encourage is to use some sort of dual anti-HER2 therapy. In colorectal cancer, trastuzumab lapatinib, trastuzumab pertuzumab, trastuzumab tucatinib, all these combinations have shown great responses, which we have not seen with single agent drugs in retrospective series, anecdotes aside. So the problem that happens is people try to get approval and then they don't get approval for pertuzumab and they end up using trastuzumab with chemo. And that, destroys the prospect for patients to participate on clinical trials. So dual anti-HER2 therapy, but always clinical trials if possible.
Perfect. Thank you very much. I appreciate it. So a few questions for Dr. Anderson. In particular from the chat, I think there's a lot of interest in using demethylating agents. And I think, much of what I was thinking about throughout your talk as we were talking about epimutations is how we can turn these into actionable clinical targets, be they actionable therapeutic targets specifically, be it through decitabine or through other strategies, really to follow the landmark example of IDH.
Yeah, I guess you're relating to Resus's question regarding decitabine. One of the problems for a broad-spectred demethylating agent is that you might very easily get toxicities when you get into clinical trials. So I think one of the main things we could do in line of the following question with the IDH mutant population from Raghav is that if you want to have higher effect of the IDH anti-IDH inhibitors, you could add in a small dose of other type of demethylating agents such as decitabine. But decitabine alone has not shown any promise for many years in solid tumors, even though it's approved for hematological cancers where it is effective, and likely due to getting to the actual tumor cells as well as also the toxicity.
Thank you. There was also a question about BAP1 that I'm looking back for and I can't find. So perhaps
I think that goes to the fact that the BAP1 mutations are in combination often with IDH mutated patients, as well as in the one we call the undetermined type mutations that are wild type for IDH, KRAS and TP53. And that actually presents a potential for improving the response rate for the IDH mutant subtype of patients if one could treat with an anti-BAP1, I would say.
And then I think the final question, which a number of people raised, is you commented in your section on epigenetics and metastasis that there were general areas of altered methylation, specifically around the Wnt pathway and also around the immune system. Within the within the sort of immune pathway that you identified, is there a specific mechanism of checkpoint that emerges as how immune evasion is happening? And is it turning off a system that we usually target, or is it identifying a new target, or do you have any comments about that?
No, we're not far enough with the really knowing what goes on in line of going from the primary tumor site to the metastasis, in line of the immune response and immune cells coming in. The the data I tried to show to all of you was that we have taken into account the complexity of the tissue by doing cellular deconvolution, but it requires a lot more in-depth analysis.
Thank you. And we're about to move on to the next section, so I'm afraid I have to leave some good questions, including from Dr. Roberts behind, so my apologies to those who have just written in, but thank you again to the speakers for a great session, and I look forward to the next one, which should start momentarily.